Hello, everyone. It is a great pleasure to see you here, to be with you all guys who are online and with whom we are going to be discussing an important topic today. This is the first edition of the Heart to Heart series, and I have a great pleasure to be joined by a friend, Dr. Valeria Paradis, who works in Netherlands. Hello, Valeria. Very nice to have you here with us.
Thank you, Dejan.
Thank you. It's not going to be a chit chat. It's going to be a serious conversation, but from heart to heart, about a topic which I think you're very knowledgeable about. It is about STEMI and multivessel disease. That being said, STEMI and acute coronary syndromes are an important, I would say, main part of our practice when it concerns coronary interventions. And multivessel disease is encountered in at least 30 to 40% of patients with STEMI. So, Valeria, on a daily basis, we treat these patients. Do you think it is a challenge, or do you think we know in all aspects what to do with these patients?
Well, first of all, I have to say thank you, Dejan, because it's a pleasure to be the very first guest of this heart-to-heart conversation. We're going to keep it really practical. We're going to share experience, knowledge, but also our clinical practice, everyday practice. Yeah, and indeed, that's something we have to face from the early phases of our career as interventional cardiologists, STEMI with multivessel disease presentation. But I think there are still a lot of burning questions about how to optimize the treatment of these patients.
What would you say? What is the main question that you think is unanswered before we dive in more about the evidence base and the practical problems? What for you is the main question when it comes to STEMI and multivessel disease that you see as an unanswered?
Well, I have two burning questions. We will dive into these questions in a bit, but I think mainly how to assess non-culprit lesions and optimal timing for complete revascularization.
I agree with you. So what I'm doing now is I'm sharing a couple of slides which will help us structure the discussion. So one of the reasons that you're here, of course, is that you wrote a very successful paper on this topic 2 years ago in your intervention, and it was one of the best downloaded and most read papers that year when it comes to state of the art. So congratulations on that. And I would urge everybody to consult this paper. It's 2 years old, but I think it still contains very important information that can help us throughout this discussion. I would now like to ask you, since this is going to be structured in 3 parts, we're going to talk about the evidence, because that is important to ground our decision making. We are then going to be talking about practical problems. And the third part of this mini discussion will be about the future of this topic and the ongoing research projects. So let us start with the evolution of the evidence. How did we start thinking and writing about this topic, and where are we today?
Yeah, I think there's a lot of data about complete revascularization. Yeah, at the beginning, the main focus was about completing or not revascularization, in which setting, during the index procedure, during the stage procedure. There was a lot of focus also on physiology assessment of the non-culprit lesions. And up to 2 years ago, when actually this paper on new intervention was published, we have already robust evidence about the benefit of complete revascularization, but mainly driven by lower rate of repeat revascularization. And we had to wait the complete trial when indeed where the heart ischemic endpoints were met. So a reduced incidence of cardiac death and MI in 4,000 STEMI patients with multivessel disease. And that was the most important piece of evidence to change the guidelines. So I was really happy to update this timeline and eventually put a class 1 indication for complete revascularization in multivessel disease patients. So I think that's the main important thing we have to underline today. Of course, all these trials have a different design, and we still have two important burning questions I just mentioned before, because indeed some trials focus on the physiology assessment. The complete trial was based only on visual assessment, so lesion severity on angiography, to guide the decision to proceed to non-culprit lesion PCI. And I think the FFR, what the FFR brought to us is that clearly showed that we can diminish treating basically the physiology significant lesions. So we can reduce the rate of PCI, but also the complication related to PCI. But how about the rate of myocardial infarction, especially the spontaneous myocardial infarction, which occurs to non-culprit lesion? And we have seen in a lot of trials that these events happen, especially in the early phase after the index procedure. So what's the best way to reduce and optimize the treatment of these patients to reduce the risk of spontaneous myocardial infarction? And regarding that, we can consider, for example, adopting an intravascular imaging approach, despite we have no data showing that a preventive PCI based on only characteristic for vulnerability on the non-culprit lesion. It's a approach that we should take. Of course, we can get some information on that. And what's also important to say is that most of the time, the non-culprit lesions, which are the most significantly severe on angiography, also have higher features of vulnerability. So probably what we saw in the complete trial, so the reduction of MI, that probably was led by the fact that we treated the most significant, significantly angiographic lesion, but this lesion also contains some vulnerability, some vulnerable plaques. So I think that's important to underline. And of course, that's also the burning question about timing to proceed to non-culprit lesion revascularization. We do know that not all STEMI come in with the same presentation, that the syntax may vary according to the patients, that most of the trial also try to exclude really complex patients, not including left main, not including CTO. So how about the timing for completing revascularization? I think that's the main things we're gonna focus on today.
So thank you, Valeria. I agree with your overview. I think it's important to reiterate that our job is to reduce the hard endpoints. And as you said, some of the trials like Compare Acute or Dynamic 3 per multi, primarily those trials, which, as you see in violet, actually investigated the FFR guiding strategy to choose the lesions, they decreased the rates of the ischemia-related revascularizations. Flower MI, which also utilized physiology, was even a neutral or negative trial. So when we speak about the evidence base, I think the most important message for me from this slide, which I think is a deep dive into the evidence base in this topic, is the following. We started in 2010 with a guideline recommendation of 2A, level of evidence B, thinking about a complete revascularization possibly in terms of revascularization in a chronic setting. So if a patient comes in an acute setting and you treat the culprit lesion, the rest of the lesions you may see similarly to what the chronic coronary syndrome is. However, the evolution of the evidence with the orange trials, PRAMI, culprit, BioVasc, actually showed us that the non-culprit lesions from the acute coronary syndrome patients tend to behave differently than the lesions in chronic coronary syndrome patients. So even though those are not angiographically culprit lesions, they seem to be unstable in a way that the revascularization can reduce hard endpoints, and this was finally proven by the complete trial. The way the complete trial stood out was that it was a pragmatic trial of several thousand patients, which did not utilize FFR, but relied on angiography to choose the non-culprit lesions that can be treated, that should be treated. And one more important thing about the complete trial, those angiographically severe lesions were not complex. The median syntax score was 7 of the non-culprit lesions, suggesting that the complete trial, which led to the recommendation that you nicely depicted to the far right of the screen, which is now 1A, to treat non-culprit lesions based on angio primarily, either during the hospitalization or up to 45 days. This is directly from the complete trial. So in summary, there are two questions from the evidence base, as you said from the very beginning. Which lesions are we going to treat, and when are we going to treat them? And the so far evidence base, actually, the largest trial, relies on angiography only, and that's the complete trial. The physiology trials were much smaller, and they did not yield any outcomes in terms of hard endpoints like in MI, like the complete trial did. So my question now to you is a practical one. The first one, how do you decide? So you have a non-culprit disease, which is half of your STEMI patients. Which of the four methodologies do you take, which of the four methods to assess the lesions and choose them for treatment?
Yeah, that's really an important question, a burning question. I don't have a clear answer on that because, of course, our center, well, we had the lead investigator of the Compare Acute and Dr. Smith, and we used to investigate all the non-culprit lesion with FFR, and that proved to be safe, and that proved to be also reduce the incidence of repeat revascularization. On the other hand, we have now also class 1 indication from the latest guidelines suggesting that we should assess the non-culprit lesion based on angiography, so eyeballing estimation of lesion severity. And I think it's important to also underline which are the limits of each technique we want to use, because during angiography, during the index, using angiography during the index procedure, of course, we can have some overestimation of the stenosis degree because of systemic vasoconstriction. We also have to take into account some temporal changes to the FFR values, because during the index procedure, what happened is that we may have an diminished response to adenosine, and we can also have some edema in the remote myocardium. So the remote myocardium subtended by the non-culprit lesion. Of course, these conditions then will evolve, and after a couple of weeks, then we will have a really reliable FFR. When we dive into this analysis, we have some papers showing that at the end of the day, the difference in the FFR values in the acute setting, subacute setting, and the chronic setting, so after 2 weeks, is basically 0.02 or 3. So the question then bounces back to you. I mean, how do we consider these differences of 0.02 in clinical practice? What do you think?
That's a very, so this is the practical segment. We talked about the evidence and we talk about the practical segments now. I'm going to once again share the slide, which I think is very important for everybody to dive in. So please take a good look, and thank you for preparing this, Valeria. So it is clear that there are, in principle, 3 strategies. Physiology can be FFR or IFR, but either intravascular imaging, angiography only, or FFR, IFR. Now, we know, as you said, from the physiology studies, that there are only small differences in the FFR values that we obtain if we do non-culprit FFR interrogation during the immediate acute event, as opposed or as compared with several days or several weeks afterwards. These can be meaningful if you think about the FFR as a cutoff guided value where you are below 0.80 or above. Now then these 0.02 or 0.03 differences will make sense. However, if you think on a continuous scale that FFR is, then I doubt that there is a lot of clinical meaningfulness to many of these measures. So there was a question from the audience actually directly related to this question. When to measure FFR or IFR to evaluate multivessel disease in STEMI patients? So what would be your answer based on what you and I just said?
Well, I think, again, from guidelines, we know when the lesion severity is 70% on angiography, based on angiography, then we should proceed revascularizing these lesions. So probably I would interrogate the lesion presenting with 50 to 70% of stenosis, so intermediate lesion, but with an important location which may have a prognostic impact on the patients.
Okay, so you would not use physiology, FFR or IFR, to choose lesions in every case which you will treat. You will rely on angiography for very angiographically severe lesions. And I think that is an important message that you are now transmitting to our audience. Let me share one more time the slide where this problem is depicted nicely. So what is the role of intravascular imaging here then? You said physiology in angiographically intermediate lesions, not in very tight lesions. If you have angiographically tight lesion, you are going to go for it. How about intravascular imaging? What is the role of intravascular imaging?
That's probably even
in deciding which lesion to treat.
That's probably even more complicated, you know, because, well, we have no data now supporting that, even though we found a plaque, which is particular with a lot of hallmarks of vulnerability, that doesn't mean that that plaque will evolve and will cause thrombosis, a thrombotic event. So we have to take into account also other characteristics, for example, local hemodynamics, what happened at the level of the plaque, how about the shear stress, how about the inflammatory status of this plaque, and also the patient characteristic, what is the inflammatory status and the hypercoagulable status of these patients. So all these things taken together will eventually determine that a vulnerable plaque will evolve and cause a thrombotic event or not. So that's why when we look back at the data, the prognostic value of using intravascular image to determine the risk of recurrent cardiovascular events was really low. We know that from the PROSPECT trial, for example. So up to now, I think that knowing that a plaque is particularly unstable and have some criteria of vulnerability, that probably shouldn't be the reason to proceed to revascularize that lesion. But of course, prove me wrong, you know, I mean, at a certain point, we are waiting also for new data showing, because this is a field we have been investigating recently, and I think we need more data on that to draw definitive.
Okay, so let me summarize as this slide is still on because it's a nice image. We will use primarily angiography, as is also part of the guidelines, to choose which lesion to treat when it comes to non-culprit lesions in STEMI. We will use coronary physiology probably in angiographically intermediate lesions, like actually we do for the chronic coronary syndromes as well. Right. And then we will use intravascular imaging as part of the ongoing research efforts to understand how we can use, in the practical sense, the information about plaque morphology, incorporate this information into our decision-making, and treat the lesions according to intravascular imaging, knowing that even in, let's say, 30% of those non-obstructive lesions on angiography, in non-culprit related arteries, in non-infarct related arteries, there are still vulnerable plaques on OCT. And we know this from a sub-study that was done from the complete trial. So I think this is an ongoing question. And for the practical reasons, most of the time we will rely on angiography, but we will also try to incorporate physiology in intermediate lesions and imaging as part of the research projects. We have another question from the audience, and that actually aligns with my interest as well. When are you going to treat these patients? I mean, you said, okay, I did open and occluded RCA. Now I have an LAD lesion. Are you going to do it in the same setting? Are you going to wait several weeks? Are you going to wait several months? What is your strategy today?
Well, there are a lot of things we have to take into account. First of all, the primary PCI, duration of primary PCI, contrast used, hemodynamic of the patients. Then we have to account the characteristics of the non-culprit lesion. So anatomy complexity, calcification, need for example, debulking techniques. Basically, the syntax score, it's part of this algorithm. And it's also important to take into account some patient characteristics, for example, renal function, the presence of diabetes. Do we need to discuss this patient in a heart team or not? I think that's also something which comes into the picture, because of course, if you have the surgeon on site, and that's during daytime, you may discuss this patient with a surgeon and then proceed with a PCI. On the other hand, sometimes for logistical reason, you have to stop and then discuss the patient in a heart team setting. That means that you have anyhow to stage the procedure, even though it was maybe a simple lesion in a mid-LAD. So there are a lot of things that come into this picture. Not all the STEMI patients with multivessel disease are the same.
Yeah, that's an important message. Thank you for that. That is exactly what we are trying to convey here as, I think, the most important message. When you look at this slide in the trials, I mean, this concept that you can treat immediately oral lesions and be of a benefit to the patient is, of course, very alluring. It's an attractive concept. However, what you just said, this is not going to be possible in every single patient with a multivessel disease after STEMI. And I think having trials like PRAMI or CULPRIT, which successfully tested this hypothesis, or BioVasc recently, which also showed the reduction of new MIs if you treat them immediately, I think this needs to be taken with caution, knowing that you can do this probably in angiographically severe simple lesions. Since this is the practical part, let me introduce you two cases I had recently. So these both gentlemen had an occluded RCA as their primary culprit. Now, what happened to them was that in the end, they had to be revascularized for this culprit, of course, and then we had to consider treating them in another setting for the non-culprit lesion. Now, what you can say, and I'm going to try to reshare it now. So what you say, and you can look at this carefully, if it can be shared, yes. So one was a more simple patient, and the other was more complex. Now, if you have two lesions where you will need to decide, how is it that you go, what is it that you go by when you're deciding? I mean, of course, a more complex patient, you're probably not going to do it immediately. A more complex lesion, it's going to wait for at least a couple of days or weeks. What is it that you do?
Well, I mean, again, when it's a straightforward non-culprit lesion, I think it's patient-friendly just to treat all the lesions. You won't expose the patient to a second risk of a heart catheterization. I mean, we know that the risk is minimal, but is always present. And also we reduce the length of hospitalization. So, I mean, that's probably a nice way of treating patients and really patient friendly. And we also have some data from the BioVasc showing and also from the multi-stars MI showing non-inferiority of this immediate complete revascularization approach as compared to stage revascularization. But when it comes to bifurcation, a really calcific lesion, as you showed in the left panel, yeah, I mean, of course, these lesions deserve a lot of attention, probably a lot of contrast, and it will lengthen the procedure, and which is not ideal during the acute setting, during the index procedure. And do not forget that, of course, I mean, when you treat a non-culprit lesion, we're talking here about the proximal LAD bifurcation and then a mid LAD. It's going to be a long stenting. If you may have any problem with a non-culprit lesion, you have already a stunned myocardium in the territory of the right coronary artery, or just actually as an infarct, and then an infarction, and now you're going to have you may always have a problem in the non-culprit lesion. And yeah, that will expose the patient to a really high ischemic risk.
I agree. So these are two different patients. These are two different non-culprit diseases. And this has not come out so clearly from the randomized trials that we have revisited. You revisited the whole evidence base, and we have not really understood from the trials that they are different patients. And I think this is very important. This is why randomized trials are, on one hand, very important to guide the practice, but it's also important how we interpret them. On the right-hand side of the slide in green is a bifurcation lesion which looks to be simple. So to treat that patient in the immediate setting, there could be benefit, as opposed to this patient being, for example, lost in the follow-up and having an event down the road, which could be due to chest pain or even in myocardial infarction. However, on the left-hand side in red, that's a whole different story. You need to prepare well for this bifurcation lesion, which is complex. It is a true bifurcation. It probably may entail 2 stents and more contrast than the right patient. So this patient, you don't really want to do at 3 a.m. after you already opened the culprit RCA. That is an important message. And when you just read the headlines and the titles of the papers, immediate non-culprit revascularization is beneficial. Keep in mind that these are fundamentally different patients. Even the complete trial, if you ask yourself which patient did the complete trial, which is the landmark trial now actually guiding us in our practice, well, complete trial did involve more sort of patients on the right-hand side of the slide. The green ones, those with angiographically simple and tight lesions. That, I think, is an important message. All this being said, Valeria, what are the next steps? I mean, we still do not have definitive answers, as you said at the beginning, to the two fundamental questions. Which non-culprit lesions to treat? We have some guidance, but not definite answers. And when to do it. Can you tell us more about the ongoing project which you're part of, actually the PI of a big study?
Yeah, thanks. Yeah, it's my pleasure to present indeed an ongoing randomized controlled trial in this setting. That's the COMPARE STEMI-1 trial, which will investigate patients presenting with STEMI and multivessel disease. As a co-primary endpoint, we will investigate a short DAPT, 1 month of DAPT, followed by prasugrel monotherapy. And in multivessel disease patient, we will investigate an OCT-guided approach versus an angio-guided approach for optimizing the non-culprit lesion, PCI. So it's important to say that intravascular imaging will be used in this trial to optimize PCI and not to decide indeed which lesions need to be treated. And I think this trial will answer a lot of questions. It remains up to now the only trial investigating only STEMI patients in this setting and also investigating only prasugrel monotherapy. It will answer a lot of questions about complete revascularization within 2 weeks, because that's also something important. You know, the recent guideline suggests either immediate complete revascularization during the index procedure or within 45 days, which is a really wide time window, you know. And yeah, how about indeed the same hospitalization, or anyhow within the 2 weeks? So reducing the risk for this patient to have a subsequent myocardial infarction and thrombotic events on the non-culprit lesion. So it will answer this question as well, and it will answer question about optimizing the PCI of the non-culprit lesion. So
Well,
of course, we wait for the results of this trial to add more piece of information to this important topic.
just one question for our colleagues watching us, a clarification. We've spoken about the role of intracoronary imaging for multivessel disease in STEMI. Your study, of which you're a PI, the OCT will serve to optimize PCI. Will it be used before PCI to inform your decision on which lesion to treat?
No, no. Again, intravascular imaging will be only used to optimize PCI. Of course, also the procedural planning will be part of it, you know, morphological characteristic of the lesion, stent sizing, but the decision to proceed to revascularization of the non-culprit lesion will be based either on angiography or on physiology, and that will be left to operator discretion. So that will be like a practical scenario, you know, it really, yeah, resembling like different typical clinical practice.
So we started off with two questions. Which lesions to treat, which non-culprit lesions to treat, when to treat them, and your study is adding the third question. How important is it that we use intracoronary imaging to guide and optimize our results when we treat a multivessel disease patient? Because it is given that we are going to be treating multiple lesions with probably multiple stents and possibly multiple stents, and we know that the events are not only coming from the lesions we do not treat. The events are coming from the lesions we do treat with stents, but inadequately. And this is a third question you're opening up, how important it is that we use imaging guidance in this vulnerable patient subset, which are multivessel disease patients with STEMI. In addition to your study, there is one more which I want to highlight, which is also large, several thousand patients, and which is ongoing. And that's the Complete2 trial, which will address the first question we asked, which lesions to treat. And it will be a physiology-guided PCI, where physiology, FFR or RFR, so resting indices or hyperemic FFR, will be used to guide our decision-making in the non-culprit territory after we successfully recanalized the culprit lesion. So Complete2, another large trial, powered to address hard endpoints, will, I think, give close to a definite answer whether physiology guidance is important in angiographically, let's say, intermediate or not critical, and of course, not very severe lesions. And that, of course, is another important trial. The last question, Valeria. You just showed a trial of 1,600 patients, large randomized trial, where you're the PI of. How does it feel? How hard it is? And how do you see the timelines for completing such a trial?
Yeah, it's a great but a pleasant challenge, let's say, to embark on this huge trial. As you mentioned, we're talking about 1,600 STEMI patients, so it's a really large trial in this setting. It's a multi-center trial, so yeah, I mean, it's sometimes can be difficult to deal with different local practice. You know, you receive questions from your co-PIs saying, I mean, how about treating this lesion during the index, during the stage? It reflects really different local practice. So I think what's important when you set up this trial, first of all, having a novel idea, something which can be competitive, original, something which is actually embrace some burning questions, you know. I mean, you want to answer some questions which always come up during the conferences and nobody has the answer for. You need to have a good guidance, a good mentor, you know, who doesn't need to be in the front line, but can have your back. And I also think that it's really important to collaborate in the best way with your co-PIs, meaning establish a good network and, you know, it's mutual trust, mutual commitment. From one side, the co-PIs, they need to commit, they need to deliver good quality of data. In this setting, for example, in my trial, all data about compliance to therapy, about bleeding, but also following the protocol for imaging and delivering good OCT quality. And on the other hand, as a PI, you need to deliver data in a timely manner, you know? I mean, they want to see your co-PIs want to see their contribution published in a timely manner. So I think it's these are the main challenges, but yeah, I couldn't be more happy to lead this trial.
Thank you, Valeria. So in the end, we've tried to give you an overview of the evidence base, the practical questions, and the ongoing research projects when it concerns the topic of STEMI and multivessel disease. Now, have we answered all of the questions that came through the chat? No. There are several that I would like to address now at the end. One is regarding the non-culprit CTO. I mean, we have talked about many trials. There was actually one randomized trial, a small trial, around 300 patients, which tested the hypothesis that opening a CTO, a non-culprit CTO, after recanalizing the culprit lesion in STEMI would be beneficial for patients. Now, this trial, with the primary endpoint of a CMR that was CMR based, showed some positive results in terms of the CMR derived outcomes. However, at 3 years, there was an increased cardiac mortality rate in patients who were treated with PCI for their CTO within 7 days of primary PCI. So once again, and with this I would finish, and I would give the Valeria last word to tell us what is her last impression. My last impression is, if tomorrow you have a STEMI patient with multivessel disease, you can consult this short conversation, look for the evidence, and try to see whether your patient fits any of the randomized trials we presented today. If it doesn't, or if you have a challenging and complex non-culprit lesion, then think twice before performing a rush PCI, stage the procedure, plan it well, and treat the patient accordingly. Valeria, please have the last word.
Well, I think you nicely summarized. So the burning questions are also really practical advice. You know, the STEMI with multivessel disease is something we have to treat every day, but plan your procedure, discuss with your colleague, discuss in her team if needed, because also that's an important piece of information. Optimize your procedure, because if you decide to proceed with the non-culprit lesion PCI, then do it at your best, and not because you have to rush into the procedure, rush the procedure. And yeah, I think that these are the main advices that we can give to our audience. And yeah, let's see each other at the next heart-to-heart conversation. Keep in touch.
Thank you. Thank you very much. So we look forward for the next issues of heart-to-heart conversations with other topics and other burning questions. Thank you very much. Thank you, Valeria, for being with us.
Thank you, Dejan.